Hello everyone. So today we will be discussing about the abortions and MTP. It is a very important topic. So let's start it. First of all, we will study what are the different types of abortion. So abortion can be spontaneous, means they occur on their own, and it can be induced. It means we are taking some efforts to expel the fetus. It can be any indication. Okay. So what are the causes of spontaneous abortion? Let's see. If the abortion is occurring in the first trimester, then the cause of the abortion is mostly the chromosomal anomalies. Okay, usually these abortions don't repeat, they are not recurrent, right? And the most common chromosomal abnormality is aneuploidy. Okay, and the most common aneuploidy which is responsible is trisomy. Okay, out of all trisomy 16 is the most common. And the another most common aneuploidy which occurs is monosomy. Okay, and out of all the monosomy X or the Turner syndrome is the most common. If specifically they ask you that trisomy 16 is common or monosomy X, then your answer will be monosomy X. Why? Let me tell you. Because tris just a minute. Yes, trisomy 16 comprise of 20% of all the abortion, and trisomy 16 comprise of 15% of all the abortions. Okay, 15% of all the abortion, only trisomy 16. And monosomy X or Turner syndrome comprise of 20% of all the abortion. So if specifically they ask you whether the trisomy 16 is common or monosomy X, then you will say that monosomy X is more common. If they in general they ask you that trisomy is common or monosomy X, sorry, trisomy is common or monosomy, then you will say trisomy, because there are multiple trisomies. Okay, and monosomy is one or two, and usually it is monosomy X. Okay, now uh, let's see what's there on the other slide. Here on the other slide we are discussing about the habitual abortion. Habitual abortion or the recurrent abortion is abortion on which is most common in the second trimester. They are most common in the second trimester. What is the definition of the habitual abortion? Three or more spontaneous abortion. Okay, the usually the etiology behind them is anatomical causes. It can be cervical incompetence or uterine anomalies. Okay, out of both of these two, cervical incompetence is more common. And there can be patient can come in non-pregnant state or preconceptionally, or patient can come in pregnant state. If the patient is coming in non-pregnant state, then we have to see that whether the number 8 Hagar dilator, which is the most thick dilator, if that passes into the cervix easily, it means that the cervix does not cannot hold that dilator, cannot sufficiently obstruct that dilator, then how it will obstruct the pressure of the pregnancy or the fetus. Okay, in a similar way we can also insert Foley's catheter number 12, which is a very thin catheter, and we have to insert 2 ml NS in it. Okay, so hysterocervicography can be done where we see the lower uterine segment and the cervix shape. And the usually the cervix and the lower uterine segment shape is at the T. You can see here they are like this. So this makes the T. This makes the T, right? Okay, and if it is a Y, then it means it is a starting of the opening. Okay, see, it has made the Y, right? And if it is the V, it means it has opened a lot. Right, it's V. and if it is U, it means that it is bulging, membranes are bulging. If it is U, it means membranes are bulging. So these all conditions, they show how they progress. Even at my this clinical stage, we remember these by simple mnemonic. Trust your vaginal ultrasound. Let me write it here so that it is easy for you to learn. Trust, T for trust, your vaginal ultrasound. So T changes to Y, then Y changes to V, and then it changes to U. Okay. Next is the, in the pregnant female, we take the which we will attempt the vaginal ultrasound, and we will see what is the cervical length. It should be, if it is less than 2.5, it indicates that it is a short cervix. And the bulging membranes means we will see whether the membranes are bulging or not, and what is the shape of the lower uterine segment, either it is T, V, Y or U. Okay, the treatment of it is cervical encerclage. Cervical encerclage can even be done in the non-pregnant female. The procedure name is lash in lash or laparoscopy. When the cervical encerclage is done in the pregnancy, then if it is done in the elective conditions, it is known as McDonald or Shirodker tapes or laparoscopic. Usually McDonald is done. Okay, now what is the time when the elective cervical encerclage is done? The time is 14 week. Okay, and this cervical encerclage which we have applied the stitch is opened at 37 weeks. Okay, if we are doing in the case of the bulging membranes are bulging, then it is known as the emergency encerclage, and the procedure name is Benson and Room. Okay, what are the contraindication? Recently it has been asked in NEET PG, if there are if there are strong uterine contraction, then it means that the baby is going to deliver. So we are not going to put the cervical encerclage in any condition. If we think that baby is going to deliver in 5 or 10 minutes, it's not that we are going to stitch the cervix, right? If there is bleeding and local infection, okay, if membranes are ruptured, then again it makes no sense. If membranes are ruptured, fetus has to be delivered, and in the case of fetal death and fetal anomaly, both. Okay, so these are the contraindication of the cervical encerclage. Now let's see about the uterine anomalies. So uterine anomalies, they also cause recurrent second trimester abortion. This all you have to read in the Mullerian anomalies chapter, but here I would like to tell you the name: unicornate, bicornate, septate and uterine diadelphies. All of this mild form is not going to cause any abortion. Only severe form will cause the abortions, and only if abortions are occurring in these anomalies, then only we are going to do the surgical repair of this, because mild varieties of them don't cause any. So their diagnosis by hysteroscopy and laparoscopy, and for unicornate, bicornate and uterine diadelphus, all of these we are going to do metroplasty, because here we have to repair the uterus wall. But for the septate uterus, we are going to do the hysteroscopic septal resection, because here no wall is there. Now the second cause of the first cause which we study was the anatomical cause, in which we study cervical incompetence and uterine anomalies. Now the second most common cause of the recurrent abortion is the APLA syndrome. What happens here? Here the antibodies, they are formed against the phospholipids. You all know that phospholipids are present in the cell membrane. So antibodies are formed against those, and the name of those antibodies are: number 1 is lupus anticoagulant, and number 2 is APLA. Okay, so the lupus anticoagulant is known as anticoagulant, but actually it coagulates. So what happens when these antibodies are formed? These antibodies are formed, then they as you have read in pre-eclampsia, then they prevent the physiological changes in the vessels. You know, during the pregnancy, the tunica media is removed by the extravillous trophoblast. We read in preeclampsia also. So now here, when there is these antibodies are there, now the tunica media cannot be removed by the extravillous trophoblast. Now there will be vasospasm, and in the spiral arteries there will be thrombosis, because as I already told you, in this APLA syndrome, a lot of thrombosis is occurring. So as a consequence of all this, the fetal deaths occur. So we can, patient will give us history in the pregnancy. If the patient will give a history related to the previous pregnancy, patient will say, I had recurrent abortion, or I had IUGR baby, or intrauterine death occurred, or early severe onset severe preeclampsia occurred due to the vasospasm, or placental abruption occurs. So these are all the previous pregnancy history which the patient will give, and we will have a clue, yes, this can be a patient of APLA syndrome. And in the non-pregnant stage, the patient can give us a history that there was recurrent thromboembolic episodes. For example, they can be stroke. For example, they can be other condition. The investigations which we do is APLA and APTT, because lupus anticoagulant, it prolongs the APTT. Lupus anticoagulant, it prolongs the APTT. So if means lupus anticoagulant is formed, then the artificial prothrombin plastin time will be increased. Okay. Yes. So the treatment of it is preconceptionally, if we have diagnosed it, then we will give aspirin, and low molecular weight heparin is only start once the fetal heart rate has come, because it gives no problem in fetal heart rate comes easily when there is this problem, APLA syndrome is there. Okay. Okay. Now Now, hormonal causes of abortion, it can be luteal phase defect, it can be hyperprolactinemia or hypothyroidism. Infections, torch infections, they cause only torch infections, they cause abortions only once. They don't cause repeatedly abortions. Please, many of you are not aware of this concept. Please keep in mind, once the torch infection has caused abortion, then antibodies are formed in the body, so they never cause recurrent abortions. Okay, please make this concept, they only cause abortion once. Okay. So next, there is syphilis. Syphilis causes recurrent abortion, but usually it causes one or two abortions. Then there are intrauterine deaths, that is, with every syphilis pregnancy, congenital syphilis pregnancy, the period of gestation it increases, and this is known as Kasowitz loss. Okay, period of gestation increases with each pregnancy. Okay. Next is blighted ovum. On ultrasound, now let's see different type of abortion on the basis of ultrasound report. One term is blighted ovum. It means that the gestational sac is formed, but no fetal pole is in between. No fetus, no fetal pole, no embryo was formed. If only gestational sac is there, then it is known as blighted ovum. And what is missed abortion? Missed abortion just means that pregnancy started, but it was stopped in between, but it was stopped or missed in between. Once the pregnancy started, but it was stopped in between. So blighted ovum is also a type of missed abortion. Okay. Now clinically there are different type of abortion. Let me tell you that when a abortion occurs, it passes through all the stages. Okay. So first of all, the first stage with which the clinical abortion passed through uh, is the threatened abortion. It means the bleeding will occur, pain will occur, but we can save the fetus very nicely. Okay. So here what will be the finding, that the os will be closed. Os is closed because uterus is not contracting to expel the fetus. Once the uterus contracts to expel the fetus, then the os opens. It means os is closed. It means uterus is still not active, and the uterus size, it is equals to the period of gestation. Uterus size is equals to period of gestation or more than that, because as we can save the fetus, and the fetus is not affected. It means the fetus is not affected, only small only little bleeding is there, and on ultrasound we can see the fetal heart rate sound, or the pregnancy being live. We can see on ultrasound. The treatment of it is progesterone. Sometimes bed rest is also advocated to the patient. Inevitable abortion, here the uterus size, it is equals to period of gestation. Now I told you, once the abortion started, first the abortion goes in threatened. Okay, if it is not treated, then the abortion goes into the inevitable stage. What is inevitable stage? Where we cannot prevent the abortion will occur. Here the uterus size is equals to period of gestation, but the os has opened. Os has opened, has start contracting, and it has opened the os. So now here we cannot prevent because uterus has become active. Now abortion will occur. Here the treatment is DNC. Now once the uterus is open and os is open, uterus has contracted and os is open, then the next stage is incomplete. Incomplete is a stage where some parts of the conception has gone out of the vagina. So in that condition, the uterus size will decrease because some parts have gone out of the cervix. So now the uterus size is decreased and os is still open because some parts are still remnant. Okay, so history of some patient will also give you history that some tissues or some clots has passed out, and here also again we have to complete the abortion. The treatment is DNC. What is complete abortion? During the process of expulsion, the whole of the fetus has come out, and the PV, the os is closed because whole the product of conception has expelled out, but the uterus will be of the non-pregnant state because nothing is there in uterus. So why the uterus will be large? Okay, so here no treatment is there, just we need to give assurance. Okay, so that was all about the clinical abortion. Clinical abortion itself is very important as we are doing revision. So I am a bit fast. So if you want to learn the different type of clinical abortions and how to diagnose them, because clinical questions do come on this clinical type of abortion, then do watch my video on my channel, how to diagnose different type of abortions. Okay, there I have it explained in detail. So now next is induced abortion. Now as you all know, we are getting lately very large number of questions on this. So the MTP Act has been amended in 2021. So first of all, you should know that there are 4 indications for abortion. If I want my fetus to be aborted, then it should come in the 4 indication, then only I can abort. First indication is if due to the pregnancy the mother life is in danger, and second condition is if due to the any anomaly of the fetus cannot survive on birth. Third is a sexual assault case. Number 4 is failure of contraception. Okay, and first now as it has been amended, so I'm not telling you the earlier condition. Now up till 20 weeks, out of these 4, any condition we can terminate the pregnancy. Okay, all 4 indication up till 20 week, and in up till 20 week 1 registered medical practitioner can terminate. From 20 to 24 weeks 2 registered medical practitioners are required, and here only for the maternal conditions the permission is given, maternal and fetal condition. It means here contraception failure cases will not be given permission for 20 to 24 weeks. For 20 to 24 weeks, 2 registered medical practitioners are required, and for only the maternal and the fetal conditions they are given, not for the case of the failure of contraception, right? And if they simply ask you, as they have previously asked, what are the conditions in which RMP can do the termination? So the answer is 24 weeks. So RMPs they have the power to do the termination up till 24 weeks. Unlimited time is there for the fetal anomaly. Okay, there is unlimited time. If the fetus has any anomaly, then it is unlimited time, because some anomalies are diagnosed in second trimester, late second trimester, and some are diagnosed in third trimester. For example, diaphragmatic hernia is diagnosed in third trimester. Now the fetus cannot survive with diaphragmatic hernia, so it need to be terminated. Due to this problem only, the MTP Act was amended. Okay, so it was told that even after 24 weeks, if an anomaly comes, then a board will be constituted and the decision will be taken by the board of 4 members. Okay, so that was about the change in the laws. So how we can abort the fetus? If it is a up till 9 weeks, we can give some drugs and we can abort the fetus, but India advocates only using this drug in up till 7 weeks. Okay, so in the first trimester we have to give the in the up till 9 weeks, if you want to give, then tablet mifepristone is given 200 mg, and after 48 hours misoprost is given. You all know that less than 7 weeks 400 is given, and 7 weeks to 9 weeks we can give 800 microgram misoprost. The mifepristone first kills the fetus, and then misoprost contracts the uterus and expels the killed fetus. Okay, in the second trimester, as the uterus is quite large and the fetus is quite large, so we need to first efface the cervix or prime the cervix. Then only we can take out the fetus by suction evacuation. So the tablet mifepristone the tablet mifepristone is given, and then the tablet misoprost 400 microgram 3 hourly for 5 doses. Okay, now as we have seen earlier that the mifepristone kills the fetus, so if it is a case of IUD, then there is no use of giving the mifepristone. Then straightway we give 800 microgram misoprost, and then again 3 hourly we give tablet misoprost 400 microgram 3 hourly for 5 doses. Okay, and the other drugs which can be used for cervical priming other than the misoprost is dinoprostone and prostaglandin F2 alpha, which is also known as the carboprost. Now, what are the surgical method of evacuation or abortion? So, one is a suction evacuation, in which we use the MVA syringe. It's a quite large syringe, and here manual vacuum aspirator we use. MV syringe is a manual vacuum aspirator, and on the front of it we attach the Karman cannula. What is Karman cannula? Karman cannula is a cannula which we attach in front of the MV syringe to do the suction. So its capacity is 60 ml. And the pressure it built inside is 600 mmHg, and up till 12 weeks we can do the abortion, up to 12 weeks, with the help of MB syringe, and it's of course a OPD procedure. No anesthesia is required usually. The another procedure which we do is DNC. Here what we do is that we dilate the cervix with a dilator, and then we will cure it. We will expel the products. So what indication it will give that all the products has been expelled? The bubbles will come out of the uterus, or the instrument, the curate which we are entering the uterus, will get gripped by the, once the uterus is empty, the uterus contracts, so the instrument which you are putting inside will be get gripped by the uterus, gripping and grating. So what is grating? So grating is ऐसे चक चक करके आवाज़ आती है, उसे ग्रेटिंग कहते हैं. ठीक है, सो ग्रेटिंग इज समथिंग लाइक दिस. See, if it is empty, then this is grating. Okay, so grating, bubbles coming out of the uterus, gripping of the curate by the uterus, and grating sound. All these are the indication that the DNC is complete. Okay, Now, if the perforation occurs, if the curate goes penetrated the uterine wall, or sometime it happens, and if it occurs, then the curate will pass without resistance. So, if we see that curate is the whole length of the curate is going without resistance, it means that we have perforated the uterus, and then immediate laparotomy is indicated. Okay. Laminaria tents, they can be also be used to dilate the uterus. Laminaria is a seaweed, and in foreign they are using dilapan, and it is a synthetic dilator of the cervix, and its mechanism is they are hygroscopic dilators. Okay, if all of these doesn't work, then we have to do hysterotomy. What is hysterotomy? We have to give incision on the uterus. Okay, and then we have to expel that products. Okay, it is somewhat similar to lower segment cesarean, but in cesarean we give a scar in the lower segment, and because it's in abortion it's quite early, so we are giving the scar on the uterus itself, because lower segment is not formed at the time of the abortion. Okay, so other methods which we are using is intra-amniotic. In the amniotic fluid, if we give hypertonic saline or urea or mannitol, then also it induces abortion. Or extra amniotic, we give ethacridine lactate. Okay, so this was all about the abortion. Here are some images which can be asked to you, so I have given here. So this is the MV syringe which we talked. 4 points you need to remember, that its capacity is 60 ml. The syringe capacity is 60 ml, quite a big syringe it is. Okay, and its pressure built in it is 600 mmHg. And number 3 is that it is a manual vacuum syringe. We need not to have any electric connection for it, and it can here by this MV syringe we can do suction evacuation up to 12 weeks. This is the ovum forceps. While we are performing DNC, this is used. This is very good. The chance of perforation is very less, and here is some space, you can say. Here the products of conception they get encaptured, collects here, and this is very blunt. It does not perforate just like curate. Okay, and there is no lock here. This is Karman cannula. Karman cannula is here, it is just before the syringe it is applied, and the vacuum built by the syringe is here. The products vacuum built by the syringe, it sucks the products of conception, and then they come out of the uterus. So the Karman cannula, size of the Karman cannula is equal, the number of the Karman cannula is equal to the pregnant period of gestation of the uterus. If it is 8-week pregnancy, then we are going to use 8 number Karman cannula. So here you can see that the procedure DNC is going on. Here we have applied the Cusco speculum, and curate is going inside. So this shape is of curate. Okay, this shape is of curate, and in the now this is the product of conception. Now it will go here and remove the product of conception, and it will come out. Okay, so this procedure DNC is going on. We can also retract the uterus with Sims speculum. The one in the picture was Cusco's, and this is the Sims speculum. Okay, and this is the Valsalem forceps. uh, it is used to also here only posterior vaginal valve is mm, retracted, and with this the anterior lip of cervix is hold. Okay, so as we are seeing in this, that the anterior and posterior both are being retracted by Cuscos. With the sim only posterior is retracted, and we hold the cervix with the Valsalem forceps. So this is a Valsalem forceps, and these are the various dilator. The most thick one, or you can say Hagar dilator or dilator, and the most thick one is the number 8, which we use to diagnose the cervical incompetence preconceptionally. Okay, I hope you got very familiar with all the abortions. Tomorrow we are going to come with the chanting of topic ectopic. Thank you.